So we exactly start at 8 p.m. So another 2 minutes to go.
So the student Dr. Mradula is having some difficulty in joining us, and this will take 2 minutes for it, sir.
Okay. Yeah. Right. She was there previously as.
Yeah, she was there, but she got logged out, and now she's again becoming a panelist.
Oh, oh.
Hello,
Hi, Amol. Now we can hear you. Yeah.
you can hear me now?
Yes, we can hear you now, loud and clear. Yeah.
Great.
Yeah. Thank you all for joining in. Just to go about, this is our monthly journal club from the Indian Society of Nephrology. Every month on the third Wednesday, we take up an interesting topic published in one of the leading journals of nephrology. And we have a DM or a DNB student, nephrology trainee, who would be critically analyzing the article. And we have the panelists, clinical nephrologists, as well as allied health subjects specialists who would be commenting on the presentation, as well as have the discussion open whether this study can be replicated in India and what are the outcomes, or whether is it meaningful for day-to-day clinical practice. So thank you all for joining in. For today, we have Dr. Mridula, who would be presenting the article from KI Reports published in the July 2024. We have with us two elite panelists who would be who would take up the who would talk at the end of the presentation about the limitations as well as the strength of the presentation, as well as of the study. We have with us the consulting nephrologist, and along with him we have Dr. Amol Mahaldar. Amol Mahaldar is a consulting nephrologist at the Manipal Hospital, Goa. Also with us we have Dr. Indu Rao. Dr. Indu is an associate professor at the Manipal Hospital, Kasturba Hospital, Manipal. She would be talking about a few topics addressed in the methodology, especially the statistical part. She would be going through briefly about it, and then the floor is open for discussion. Thank you. Thank you all for joining in. Mridula, you can start your presentation. Mridula, if you can share your screen.
She has just joined, sir. She had some connectivity issues. She has just joined, I
Okay.
think.
Right.
Mradula, you're able to hear us?
Yes, sir, I'm able to hear you.
Yeah. Can probably share your screen now.
We have been running this journal club for the last 18 months and I think this is the first topic on mineral bone disease. Most of us have been, most of the topics recently have been on IgA and the therapies towards IgA. And I think it would be interesting to go through this large cohort and get an intro to whether are we seeing a similar mineral bone disease pattern in our population, and and what are the pattern of use of calcium mimetics, and what does our population actually behave in terms of fracture risk? So Mridula, yeah.
Good evening, sir. Good evening, respected faculty member and my seniors and my colleagues. Today's Journal Club presentation is on lower parathyroid hormone levels are associated with reduced fracture risk in Japanese patients on hemodialysis. It was published in Kidney International, and it is a latest article. It was published in July. It was published in July 2024, and coming to the introduction part, and to introduce the CKD MBD, it is defined as a systemic disorder of mineral and bone metabolism due to CKD, and is manifested by one or a combination of the following, which can be abnormalities in the serum calcium, phosphorus, PTH levels, or vitamin D metabolism, or it can or abnormalities in bone turnover, mineralization, volume, linear growth, or strength, or any vascular or other soft tissue calcification. So, what is the spectrum of CKD-MBD? CKD-MBD has got two ends. At one end is the high turnover disease, and at other end is the low turnover disease. So, as the PTH level rises, there is hyperparathyroidism, which leads to high turnover, and there it is manifested as osteitis fibrosa. At other end, when the PTH is suppressed, it leads to low turnover, which manifests as edynamic bone disease or osteomalacia. So, secondary hyperparathyroidism is a common complication in patients on hemodialysis, with about 70 to 80% of patients receiving treatment or medication for this condition. So, what are the target levels recommended by KDIGO for stage CKD stage 5D? So, KDIGO recommends a range of approximately 2 to 9 times the upper limit of normal for the SA, and they suggest marked changes in the PTH level in either direction within this range prompts an initiation or change in the therapy to avoid progression to a level outside of this range. And this is the this highlighted part is the different recommendation, the latest recommendation in the 2017, which is different from the prior recommendation by the CKD 5D. Although the level were same in the previous recommendation also, but any marked change is now considered as a marker that you need to change the treatment, or we should um, uh, decide the treatment strategy accordingly. So, what is the effect of persistently elevated PTH level? And it leads to high turnover bone disease, as we already discussed. But it has got different effect on the cortical bones and different effect on the trabecular bone. So, in the cortical bone, it leads to excessive bone resorption and leading to deterioration of the cortical bone architecture. However, on the trabecular bone, it has got a anabolic effect, and it leads to formation of the trabecular bone. Then target range in the PTH, target range for the PTH in the current guidelines, current clinical guidelines are mainly based on its association with mortality. And to date, several observational studies have examined the relationship between PTH levels and fracture risk in patients on dialysis with mixed result. And there are conflicting evidence as to whether PTH level are associated with fracture risk, and whether the relationship is linear or U-shaped with increased risk of fracture at both the ends. So one more important thing we before we go to the general is the PTH assay, and it is based on the structure of the PTH. So we know that PTH is a 84 amino acid peptide, and it has got N-terminal and carboxy terminal. So the intact PTH versus the bioactive or whole PTH are two different assays. Intact PTH assay assesses the level of PTH by amino acid 13 to has got the antibody directed against the 13 to 32, and the other antibody, which is capture antibody, is from 39 to 84, while the bioactive assay is against the initial 6 amino acid, and the bioactivity of the PTH is related to the initial amino acid sequence only. So this assay is more specific for biologically active PTH, and the other assays can detect the carboxy fragments, which are also there in patients with CKD. So it can lead to overestimation of the PTH value. Now, what is the study rationale? So, the study was done to examine the risk of any fracture and site-specific fracture across a range of PTH level using prospective data from nationwide registry of patients on dialysis in Japan, and to study the association between 1 year or 2 year percent change in PTH levels in subsequent fracture risk. It was a prospective cohort study, and the data source was Japanese Society of Dialysis Therapy renal registry data, and the study population was the Japanese patients taken from the registry, and the database covers nearly all patients on dialysis in Japan, and the response rate to the questionnaire was about 98.6% in 2016 and 98.8% in 2017. And data was also collected for the hospitalization event for the first time in 2017 in this database. Though the inclusion criteria for the study was patients who were of age more than 18 years, and they were receiving maintenance hemodialysis or hemodiafiltration thrice weekly for more than 3 months. And they had data on serum albumin, calcium, phosphorus, and intact or whole PTH at the end of 2016. And data about the hospitalization was also available in 2017. Exclusion criteria were patients who were undergoing peritoneal dialysis or hemofiltration, or were undergoing hemodialysis for less than or more than 3 times per week, or were having any missing data on albumin, calcium, phosphorus, intact PTH or whole PTH, or hospitalization data are those who discontinued hemodialysis or hemodiafiltration, and or those who underwent for kidney transplantation. This is the study flow chart, which is showing that a total of 319,110 patients who were undergoing dialysis were approached for the study, and out of which 44,872 patients were excluded due to various reasons, like having age less than 18 years, or undergoing peritoneal dialysis, or were undergoing hemofiltration. The duration of dialysis was less than 3 months, or the frequency was less than or more than 3 times per week, or were having missing data. Then later, 274,238 patients were undergoing hemodialysis or hemodiafiltration thrice per week, and out of which approximately 24,000 patients were again excluded due to missing data on albumin, calcium, phosphorus, and intact PTH or whole PTH. And then in the further study, those who had the all the data available, 69,000 of the patient approximately 69,000 of patients were excluded because of the data missing on hospitalization, or some underwent kidney transplantation, or some of them discontinued hemodialysis and hemodiafiltration, and a total of 1,80,333 patients were included in the analysis. The primary exposure point for the study was intact PTH level at the end of 2016, and secondary exposures were 1 year or 2 year percentage change in intact PTH levels between 2015 and 2016, and 2014 and 16 respectively, and the serum calcium and phosphorus level at the end of 2016. So What were the primary outcome? Primary outcome of the study was composite of hospitalization for hip, vertebral or other fracture during 2017, and secondary outcome was hospitalization for site-specific fracture. This is a schematic illustration of the study design. As we discussed, the data was collected, and at the end of 2016, PTH level was um data was collected on PTH level, and the patients were follow up to look for its relations with the risk of fracture. And so this was a one-time PTH, baseline PTH, and the risk of fracture. And then secondary analysis, the patients were assessed for 1 year change in the PTH level, and then second was the 2 year change in the PTH level, and they were followed up to look for the change, to look for the fracture risk. Statistical analysis, logistic regression analysis was done to estimate odds ratio for overall and site-specific fracture associated with IPTH, calcium, and phosphorus. And biochemical parameters were both analyzed as continuous and were also categorized into decile. And to examine the potential non-linear association between exposure level and the fracture, we use restricted cubic spline, which will be explained by the moderator, and analysis based on the adjusted logistic regression model with 3 nodes at the 30th, at the 10th, 50th, and 90th percentile. The method, odds ratio and 95% confidence interval for the fracture were adjusted for incremental sets of potential confounders. So they divided the data into 2 models, and it was adjusted for the potential confounders like age and sex, then dialysis duration, what was the cause of kidney failure, and dialysis modality, what was the BMI, KT by V value, and normalized protein catabolic rate, history of cardiovascular disease, history of hip fracture. And the model 2 was adjusted for level of hemoglobin, level of albumin, level of creatinine, total cholesterol, and C-reactive protein. Here we can see the result, the baseline characteristics of the patient. We can see that the total of uh, uh, hip fracture was seen in around 4.5 percent of the patients. They had the history of past history of hip fracture was seen in around 4.5% of patients, while the mean value for calcium was 9.1 milligram, and for the phosphorus it was 5.2, and IPTH the median value was 141. And in the other here we can see the patients who were having high decile of PTH level, that was more than 337 picograms per ml. The age of the patient was relatively younger as compared to the people who were on patients who were in the decile 1 to decile 9. The age was around 64.7, and the duration of dialysis was also longer in the people who were having higher level of PTH level. Also, the patient, the cause of CKD, cause of kidney failure in patients who were in the 10th decile of PTH level was 32.7%. And the patient were having relatively higher BMI as compared to the patients who were in the lower decile of PTH level. And the creatinine level was also higher in the patients who were in the higher in decile of PTH level, and calcium value was lower as compared to the other groups. And the mean value of the value of phosphorus was also relatively higher in patients in the higher decile of PTH level. The baseline PTH and fracture risk during the 1 year follow-up, there were total of 3,762 fractures requiring hospitalization, out of which 1,361 were hip fracture, 551 were vertebral fracture, and 850 were other fractures, and a total of 3,708 participants experienced at least one fracture and 54 experienced two fractures, and a total of 3,375 patients participants died during the follow-up. Here we can see the logistic regression analysis for association of level of intact PTH and the fracture. So here we can see that uh, the analysis was done for any fracture, hip fracture, and vertebral fracture, and the level of PTH was divided in the deciles, and there was 10 deciles were there, and the lowest decile, which was less than 39 picograms per ml, was considered as the reference range, and all other parameters were all other deciles were the risk in all other decile was compared to the reference range. We can see that the model which we discussed in the statistical analysis part, that model 1 and model 2 were for the confound to remove the confounders, while this one was the unadjusted odds ratio. So unadjusted odds ratio was not showing any significant trend or risk for the fracture, while we can see in the model 1 and model 2, for any fracture, the odds ratio, as the decile is going up, the odds ratio is also rising, and at the seventh decile in model 1, we can see the odds ratio is 1.25, so it is the highest, and after that it is almost a linear, or it is almost similar, it is 1.23 and then 1.25, and in the model 2 it is highest at the eighth decile, which is 1.27, and then it is 1.25 and 1.26, which is almost linear. Now in the hip fracture group, we can see the odds ratio is highest at the seventh decile, which is 1.8, and it is
Mridula, if I may please interrupt you here, do you have a pointer by any chance? It's a very busy slide and there is just too much data for us to follow. Would you point out to the this one that you're, if you right click, I'm sure you'll find a pointer there. I'm sorry, I'm not very conversant with Zoom, so I can't guide you on this. Anyone who's more conversant with Zoom could tell you how to get a pointer on the screen. Please right click on the screen that you're sharing with us and you possibly will get an option of a pointer.
Sir, I'm not getting any option for pointer right now. Sir, I have highlighted the important the odds ratio in the hip fracture group, which is 1.8. It is the highest in the seventh decile in the hip fracture group. So I just wanted to convey that that the fracture risk is highest in the in the seventh decile group for the hip fracture, and after that it is almost plateauing. It is 1.57 and 1.58, 1.59 and 1.48 in the subsequent decile of the PTH levels. Sir, sorry, I don't have any pointer to, but I have highlighted the
No problem. No, it's fine. If you can't find a pointer, just be slightly more deliberate. Let the audience at least focus on what you are saying, because I'm sure you're familiar with your slides, but most of them won't be.
Okay, sir.
Please carry on.
Yes. Okay, sir. So I would like to discuss it again, and the authors have divided the outcome into three part. That was any fracture group, hip fracture group, and the vertebral fracture group. So as per the decile, which was decile 1, for each group was considered as reference range. It was less than 39 picograms in all three groups, and it was considered, the assumption was made that based on the analysis, that the fracture risk is lowest for the PTH target range of less than 39. So they considered it as a reference range. Then in the any fracture group, we can see that there are three three ranges, three odds ratio group we can see. So in the unadjusted group, we can see the odds ratio is almost 1 in all the groups, and there is no particular trend that it is rising or falling. It is There is no particular trend. But in the adjusted models, which is model 1 and model 2, for the mo- model 1 and model 2, in model 1 we can see that as the decile is increasing, 10th, we can see the first decile is having a odds ratio of 1.08 in the model 1, and then gradually we can see up to decile 7 it is becoming 1.22, and then it is 1.25, and then it is 1.23, and then it is
Uh,
1.25. So we can
so,
see a trend
so,
that
so you can concise it by saying there is a linear trend rather than reading it out each of the deciles.
Yeah, you can just
That
say
way,
it's
yeah,
what the authors have said. There is a
yes,
monotonously linear correlation between the odds ratio of risk of any fracture as the deciles of this one increases. You could just summarize it that way.
yes, sir.
And Dr.
So
S.K. Agarwal has given a hint that you could use your mouse cursor itself if you play it on the screen. I do not know if that will work. You could try that too.
I am using it, but I think it is not visible for
Not coming. Yeah, we can't see it. Fine.
yes.
Please carry on.
Yes, sir. So in the hip fracture group, again, we can see that the red circle is showing the highest odds ratio, which is at the seventh decile. In both model 1 and 2, it is 1.81 and 1.89. So it is highest. And after that, it is almost plateaued. So it is linearly rising and then it is plateauing. While in the vertebral fracture group, there is no such relation with the rising level of PTH. It is almost not it is there is no such linear trend with the level of PTH in vertebral fractures. So this was the finding. And then now to understand it better, we can see that the adjusted odds ratio for any fracture group, as the level of PTH is rising, we can see that in any fracture group it is also rising. The odds ratio is also rising, which indicates that the risk of fracture is also rising. And in the hip fracture group also, we can see that the PTH, as it is rising, the risk of fracture is rising. But one important thing to point out here is that the curve is more steep, which is showing that a higher risk of a fracture in hip region at even at the PTH level of 100 to 200, and it is highest in PTH level between 200 to 300. And then after that, it is almost plateauing, but no such trend is seen in the vertebral fracture. As we discussed, it is mainly composed of the trabecular bone, so there is no such relationship with the rising level of PTH in the adjusted odds ratio for vertebral fracture. Then for the predicted probability of any fracture uh, with across the intact PTH level, and when it was stratified according to the age, so we can see that the graph, which is graph 1 is for the any fracture, then there is middle one is for the hip fracture, and then it is for the vertebral fracture. We can say that the gray line is representing the risk for fracture in the any old people age more than 73 years. So we can see that they have got the higher risk of fracture with high level of PTH as compared to the patients who were younger, and it is also increasing with the level of PTH. Similarly, in the hip fracture group, the risk of fracture is rising as the IPTH level rises, and it is highest with the age of more than 73 years, and it is also again linearly rising. Here the risk is, again in the vertebral fracture, is highest for the vertebral fracture, but there is no such linear increase. It is increasing and then it is decreasing also. So level of PTH uh, is higher level of PTH is associated with decreasing risk in vertebral fracture. Now coming to the stratification according to the sex. So we can see that the female patients are having higher risk in all the group. Interesting fact we can see in this slide is that as the level of PTH is increasing, the male are having higher risk of fracture as compared to the females. Then, in according to the BMI, in both the any fracture group and the uh, hip fracture group, we can see that the highest risk is for the patients who are having low BMI. Then this is the forest graph, which is showing the risk of odds ratio of any fracture per doubling of intact PTH level, but the p-value is not significant in any of the group. The significant p-value we can see here is for the vertebral fracture. Vertebral fracture are patients who are male are having higher risk of fracture with the rising or doubling of the intact PTH level, and patient who are having higher albumin level are having lower risk of vertebral fracture, and p value for both of these both of these characteristics are significant. Here we can see that the fold of PTH fold change and the risk of fracture. So in any fracture group it is rising again, and in the hip fracture group it is rising with the fold change in PTH, and in vertebral fracture it is rising. It is almost linear. It is not showing any particular trend. Then this is the odds ratio, the per 30% reduction in the intact PTH level. In vertebral fracture, the the odds per 30% reduction in the intact PTH level. The unadjusted is showing no such, it is 0.98 for the any fracture, then it is 0.97 for the hip fracture, and for vertebral fracture it is 0.98. Then in model 1, it is 0.98 for any fracture, and for hip fracture, it is 0.97, and for vertebral fracture, it is 0.99. And in model 2, it is 0.97 and 0.95 and 1. So in vertebral fracture, this is almost equal to 1, while in the other fractures or any fracture, hip fracture, it is below 1. So decline in PTH level is associated with lower risk in patients with any fracture or hip fracture. Now, with respect to the phosphorus level and calcium, the higher phosphate was associated with increased risk of fracture, while there was no such association seen with calcium levels. Coming to the discussion part, and higher PTH levels were incrementally and approximately monotonically associated with fracture risk, with the lowest risk at the lower end of PTH distribution. And 1 year change in PTH level was linearly associated with subsequent fracture risk, regardless of the baseline PTH levels. And these associations were more pronounced for hip fracture, whereas there were no such association for vertebral fractures. So there we can see the old study which was published in February 2000 in American Journal of Kidney Disease. We can see that according to the previous studies, we say that the curve association between the PTH level and the risk of fracture is U-shaped, and we see according to this study, when the parathyroid hormone level were evaluated, this study determined that the patients with lower serum PTH level are more likely to sustain a hip fracture than patients with higher PTH levels. So, according to previous saying that we used to consider that a low PTH level is also associated with higher risk of fracture, and as the level of PTH rises, again there is a increased risk of fracture. So we have to maintain a particular range for PTH level in CKD patients. So, in support of this current study which we are discussing, there is a study which was done to look for the association of alkaline phosphatase and parathyroid hormone levels, international variation and association with kidney with clinical outcomes in DOPS. It was seen that normalized PTH level that the J there was a association was J-shaped. So as the level of PTH was rising and the level of PTH was rising, there was an increased risk of fracture. Although the association was weak, but the association was seen in a linear pattern. Another study, which is a meta-analysis, it has shown that uh, more substantial reduction in fracture risk with cinacalcet and newer intravenous calcimimetic, which are effective in controlling the PTH level, improved the adherence and potentially better safety profile and lower the risk of fracture in patients who are CKD5. The relationship between PTH level and the fracture risk is particularly evident for hip fracture, which are mainly composed of the cortical bone. And as we discussed, it has got high turnover effect on the cortical. It has got a catabolic effect on the cortical bone, while there was no such association with the vertebral side fracture, as they are composed of mainly trabecular bone, which has PTH has got anabolic effect. And in patients who are CKD5, we see that the risk of fracture is usually assessed based on the bone density at the hip side. So it is a better marker for assessing the risk of fracture, and level of PTH should be uh, targeted according to that. The association between PTH level and fracture risk was consistent regardless of the type of PTH assay used, and higher serum phosphate level were associated with increased fracture risk. Now, what are the strengths of this study? It was a large nationwide cohort with substantial number of fracture events, and it was a prospective study design, and it gave more information about the specific fracture site, like vertebral fracture, hip fracture. And now coming to the limitations of the study, it was the only it included only patients who were requiring who were having fractures which required hospitalization, and fracture events were recorded by the local medical staff, and it excluded a large number of patients, which like about 69,000 of patients, and PTH level were measured at different times in different in clinical practice. So as there is a circadian rhythm for the PTH level, and different medicines are taken at different time which can affect the PTH level, so this might have affected the study result. And the study also lacked the data on the use of calcium mimetic and active vitamin D intake in patients, and there was no data about the bone mineral density and bone turnover markers, and study population was limited to the Japanese patients on hemodialysis, which limits the generalizability of the result of this study. Now, coming to the conclusion, this study found an approximately linear relationship between the lower PTH level and reduced fracture risk, particularly for hip fracture, and reduction in PTH level over 1 year were linearly associated with decreasing risk of subsequent fractures, even in patients with low baseline PTH. So this study highlights the need for randomized clinical trials to test whether intensive versus standard PTH control reduces the fracture risk in patients on hemodialysis.
Thank you, Mridula. Thank you for the presentation. Before I invite the two panelists for the day, I would like to invite Dr. Indu to share a couple of slides on the methodology, especially in terms of the restricted.
It was a data was collected Society of Dialysis Therapy.
Mridula, if you could stop sharing the screen, and I'll invite Dr. Indu to share her screen to explain the statistical concept used in this study, and then I'll invite Dr. Amol and Dr. Ranjit to join in. Dr. Indu.
Darshan, thanks upfront, because Mridula said moderators was explain the restricted cubic spline, and I'm sure Dr. Ranjit and myself have tried, but really thanks for arranging Dr. Indu to do the job more professionally.
Yeah.
Statistician.
I was up all night reading RCS.
Good evening, everybody, and thank you, Darshan sir, for giving me this opportunity. So, first of all, a disclaimer: I'm not a statistician; I'm a nephrologist.
Oh, great.
So, I myself have a very somewhat basic understanding of restricted cubic spline regression, but I'll try my best to explain to everybody how this actually works. So, I'm going to cover two aspects in my presentation today. The first is restricted cubic spline regression, and the second part of my presentation will be about how to handle missing data. So I'll talk a bit about imputation and multiple imputation. So when exactly to use
Some part of your screen is not seen.
Yeah. I think you have opened the chat box or something like the floating.
I'll just try and see what I can do. So is this any better?
No, it is still there, but
Still
it's
are
okay.
missing
You can
parts of the
proceed ahead.
screen.
No, I
Is
think
it the chat box on the right side or that panelist one?
Okay, the panelist one. Okay, I'll just hide that.
Yeah.
Yes.
All
better.
right. Better now? All right.
Yeah, almost.
Okay. Yeah, okay. So sorry for that. So let's consider two variables, right? So let's consider a predictor or an independent variable X and an outcome variable or your independent variable Y. Sorry, dependent variable Y. And let's say you're trying to model the relationship between X and Y, which means you're trying to predict what happens to a variable, outcome variable of interest. Let's call it Y with as the value of X changes. So when you do any sort of regression analysis, be it a linear regression, logistic regression, or even Cox regression, there is always this assumption of linearity. So when you're doing linear regression, for example, the assumption will be that X and Y are linearly related, which means that there is a straight line relationship between the two. When you're doing logistic regression or Cox regression, the assumption is that the log odds of the outcome variable y or the log hazards of outcome variable y when you're doing Cox regression is linearly related to the predictor variable x. So irrespective of what regression you're using, there's always this assumption that there is a linear relationship. But when it comes to real life situations, you won't always have this sort of a linear relationship. Sometimes it's a bit more complex, right? So this particular slide is just showing some of the relationships which you may find when you are analyzing. So this, of course, is the linear relationship just talking about. You can also have, some curves of this sort that you can see, and they all have they all are named after particular functions. So these are some simpler non-linear relationships, but sometimes the relationship between two variables can be much more complex than what these figures show as well. So how do you really model these relationships? And then, so that's where spline regression comes in. And this is a method to model non-linear relationships. And this can be added to any regression analysis, be it linear, logistic, or Cox. So let's just take one example. For a second, let's just ignore this blue line over here. So so here in this figure, what you can see is that there is a independent variable or your predictor variable x, which is plotted along the x-axis, and along the y-axis there's a variable y, which is your outcome variable. And these black dots here are actually representing the value of the outcome variable y for a particular value of x, right? So this is how the data set looks like. So when you're doing spline regression, what you do is you're actually dividing this entire data sets into pieces or intervals. So how are you actually dividing them? So that you're doing using something called knots, which are represented by these straight lines that you can see here. So these knots are nothing but particular values of the variable x, and these are generally based on quantile values. So as you can see in this particular example, there are 5 knots, right? So 1, 2, 3, 4, and 5. And these 5 knots divide the entire data set into 6 intervals. So interval 1, interval 2, interval 3, and so on. So you have 5 knots, 6 intervals. So uh, so there are particular conventions where the knot should be placed, and generally when you do these RCS analysis, the knots are placed as per the convention. So in this study, for example, they've used 3 knots, and as per convention, the location of the knots were at the 10th, 5th, and 90th percentile. So generally, there's a convention about where these knots should be placed. So what happens is in each of these intervals, within each of these intervals, you are actually plotting the relationship between x and y using what is called a cubic polynomial curve, which is this, right? So in each of these intervals, you're using the cubic function, you're drawing a cubic polynomial curve, and at the end of this, all these curves are basically just stitched together such that they intersect at these particular knots. So at the end of it, what you get is a very beautiful curve which looks like this. And because you're using the cubic function to model the relationship between x and y, it's called a cubic spline. If you use the linear function or a linear equation, it will then be called a restricted linear spline. Why is it called restricted? It's called restricted because at the tail end, which means before the first knot, after the last knot, the relationship is modeled as being linear. So it's going to be made of pieces of cubic polynomial curves here, but at the end here and here, it's going to be a linear relationship. So I'll just skip this. I've already covered this, I believe. So coming to what was shown in the figure 3 of this particular paper, what they've done in this particular figure is they've modeled the relationship between intact PTH and the adjusted odds ratio of any fracture occurring. So by adjusted, it means that the model has been adjusted for factors such as age, gender, dialysis vintage, and other such parameters. So this is the curve which they actually got. This is the restricted cubic spline regression curve which they have made, and this gray zone here represents the 95% confidence interval. So for example, if at a value of PTH of 200, your adjusted odds ratio of any fracture would be around 1.5, let's say. So that's how you interpret this curve. This curve is more or less linear, not really, but more or less linear. Whereas in this particular curve, you see that as the value of PTH increases, the odds ratio of hip fracture is going on increasing until a particular cutoff. So this particular point may be around 240 or so. After that, the odds ratio of hip fracture is more or less plateauing. In fact, it's slightly reducing. So that's how you interpret the restricted cubic spline. I hope that was more or less, that brought some clarity. So the term spline actually comes from boat making, where draftsmen used to use these thin, flexible wooden strips. These were called spline, and they used to be held in place with these lead weights called ducks or whales, because they look kind of like a whale, and this forces the spline to bend and form a smooth curve. So that's where the term spline comes from. This I'll just skip in the interest of time. And coming to the next part of my presentation, which is handling missing data in research. So as we all know, having missing data in your data sheet is very common. And how do you actually handle it? So there are a few ways that you can do it. The first thing is you just exclude the cases where you have missing data, right? So that's called a complete case analysis. Just exclude cases where you have missing data. Big problem with this sort of an approach is that if you have large amount of missing data, you'll end up, deleting a lot of rows, in which case your data set becomes much smaller than what it was earlier. So a better and more preferable way of doing it is something called the imputation analysis, where you replace the missing values using plausible values. So that can be single imputation, where you replace the missing values with either mean or median. So let's say you have a data sheet, you have serum creatinine values, there are a few values missing. What you do is compute the mean creatinine or the median creatinine based on how it is distributed, and you just replace the missing values with those mean or median values. So it's as simple as that. But there are some issues with that, right? So a more preferable way of doing it is to do a multiple imputation. So what happens here is, here for every missing value, this method imputes multiple values using regression models, and this leads to the creation of multiple data sets in which missing values have been filled in with plausible values. And then each of these data sets is analyzed separately, and then all these results are pooled together across the imputed data sets. So the advantage of this method is it incorporates uncertainty about the true value of imputed variables. So a very common way in which it is done is by something called the MICE method, or the multiple imputation by chained equation method. I'll just skip through this. I think it might be a bit too complex to actually discuss how actually it works. So I'll just skip through this. So in this particular study, they've used 10 data sets, because what they have mentioned is that the proportion of missing data was less than 15%. So generally, the White et al.'s rule of thumb is that the number of imputed data sets should be at least as large as the percentage of subjects with any missing data. So if you have 10% missing data, you have to have 10 imputed data sets. If you have 15% missing data, you should have 15 imputed data sets, and so on. However, generally speaking, 5 to 10 data sets are generally sufficient for most cases. Yeah, so with that, I'll just pause sharing. I hope that was useful.
Thank you,
Yes,
Dr.
Dr. Indu, it was.
Yeah, Dr. Amol and Dr. Nair to take over.
Yeah, so if I can just start, Dr. Mrudula, nicely analyzed. You have brought out all the points that the Japanese authors tried to get from the study that they had started with, right? Their basic premise was that there is a linear relationship and lower is better. And you have actually in your analysis mentioned what are all the limitations that are there in this. But these are declared limitations which the authors themselves have come out in the article. Beyond that, there are some limitations that we have to interpret. For example, they've excluded anybody with less than 3 times a week dialysis. So that means half of Indian population on dialysis is not going to be eligible for this kind of analysis. Also, with now the concept of incremental dialysis, where dialysis started once a week, twice a week, and then increased. A large data set of patients would not be eligible only to be analyzed for this kind of a study. Second thing is they have gone purely by the fracture incidence, no? And that too only those who require hospitalization. A large number of fractures might have not required hospitalization also. Besides, it is quite counterintuitive, their entire premise, because at low PTH levels, we are supposed to see adynamic bone disease. But adynamic bone disease might not always cause a fracture. It has other implications like low HbA and bone pains and other things, which you would only find out on a bone biopsy. And bone biopsy is very rarely done. So these were some of the things. Some of the other things are that Japanese patients seem to be quite different. And in a commentary which is there, which is attached to this article, Yardul, who's an author from Europe, has commented that Evenpol has done some analysis that compares Japanese patients and Belgian patients, and has found out that Japanese patients have low PTH otherwise also, and for that given low PTH they have even low bone turnover also. So somehow Japanese patients seem to be different. They are saying that maybe it is related to the BMI, the vintage of dialysis, the fact that they target a lower hemoglobin and use lower doses of EPO also. Another thing that they have missed to measure is actually alkaline phosphatase, which is quite easy to measure. Calcium and phosphorus, if they are measuring alkaline phosphatase, bone specific should have been easy. Of course, other bone tumor turnover markers are more expensive, more difficult. Maybe not relevant to our practice also. But calcium, I think alkaline phosphatase should have been included in the analysis. That would have also correlated. Dr. Nair, any inputs from your side?
Thank you, Dr. Amol. I just was looking at the baseline characteristics and the deciles of intact PTH to start with. When I look at the final decile, if I have a person whose BMI is more than 22, whose albumin on an average is more than 3.6, whose creatinine is higher, I would expect this person is actually doing very well on dialysis in my cohort. When compared to the first decile, where the albumin is more or less the same, but the creatinine is lower, the BMI is lower, and the intact PTH is also lower. You see, if I'm told that a patient has got a better weight, a better albumin, a higher serum cholesterol, and the CRP is more or less matching, and the BMI is high, I would say this patient is probably eating better. He has better MIA markers, malnutrition, inflammation, atherosclerosis markers. That's number one. The second thing, I could not understand why the rationale behind creating these two models, Model 1 and Model 2. Model 2 possibly looks at the malnutrition and inflammation. That's separate. I mean, if I could get that slide back of the two models, the authors never have really specified why have they created these models, with what intent have they created this model, what specific part of CKD or CKD5D are they targeting by this model. Because I would say that if I'm a researcher, if I create a model, I would possibly be looking at a subset of patients who fit into this model. That's the second thing I had with this one. Otherwise, the data set is very large. The overall baseline population, of course, is excellent, and the Japanese are known to be extremely meticulous in their data keeping. And of course, the Japanese, they themselves claim that their CKD MBD guidelines are very different from the rest of the world. There are enough studies, in fact, they're quoted as references in this article also, of how Japan as a region differs from the rest of South Asia and Europe when it comes to whether it's a DOP study or the level of intact PTH. And the last, of course, something which I always feel all residents must read is disclosures. Every single author has been receiving personal fees from companies which are heavily invested in the production of calcium mimetics and vitamin D analogs and are actively researching mineral bone disease. So there is a definite, how should I say, conflict of interest over here. Because when you find something which is counterintuitive, like what Dr. Amol has said, to what we have read all across till now, and possibly we see in our patients too, we should look for reasons why. So those are my response. If the moderators or anyone could highlight why were the two models created separately? Because if you actually see, I'm sorry, I have a printout, but it's not very good.
Mridula, can you just put that slide where you had shown the characteristics for each of the model 1 and model 2? Thank you, Dr. Nair, for pointing it out. I think the first model talks more about the demographics and the comorbidities which are there. The second model talks more of the biochemical changes. Can you put that slide, Dr. Mridula?
They were considered as potential confounders, and that's how they have created two different models.
Two different models.
That's what they have said in the discussion.
One is mainly talking about the demographics, their age, sex, comorbid course, and the second thing is about a couple of things about what I could get from the article. One thing, it has taken the PTH and the risk of fractures in 2017. Now it is 2024. So it's almost 7 years back. And we know that a lot of calcimimetic, synthetic PTH, that the way we treat our patients with hyperparathyroidism has changed considerably in the last 7 years. So considering that, definitely, I mean, how relevant, it was just published in KI. So I was surprised that, I mean, why did the Japanese not analyze the data from 2024, 22 or anything, is one thing that actually came into my mind. The second thing which came to my mind is what they stressed upon is the secondary objective, where they looked at the change in the percentage of PTH in the previous year. So if there was a 30% reduction in the PTH, and they could realize that the fracture risk came down. So it is a change in the PTH and the absolute PTH value, which was more important to reduce the risk of fracture. So that I think was more important. And coming to Dr. Amol, your thoughts about alkaline phosphatase, probably what I could get it, one, probably they will not be doing the bone alkaline phosphatase. And both of them, PTH and alkaline phosphatase, almost have similar kind of a relation. They may not be exactly the same. If PTH is increasing, you can see alkaline phosphatase also increasing, and vice versa. So that could be, if they are already using PTH, probably that's maybe one of the reasons why I could think they would not have used such a cheap option of alkaline phosphatase if they have the data for it. Yes.
I think the Japanese guidelines have been updated only two times, 2008 and 2013. And the 2017 KDIGO guideline update has not been followed up in Japan. They set up something called a CKDMBD.jp, and they have a special logo, and they are discussing from 2017 onwards. But they are still following the same guidelines, and their PTH targets are very low. They have kept it. That's why that first decile is so low.
Yeah, that is mainly because they have done the initial primary analysis and they have
Hmm.
found out that the lower decile had the lower risk of fracture.
Lowest risk.
So
Yeah.
that is the reason they have taken it as a reference range. And the reason 2017 they said they have chosen is from that year they started looking at the hospitalization rates in the registry. So
Hmm.
prior to that, they did not have the registry which looked into the hospitalization rates. So they chose 17. If they have already started maintaining the hospitalization, why not take 22? Why just take uh,
Yeah.
a model? Because 2017 is what I couldn't get my head around. Yes, sir. Uh, so as we were discussing, uh,
The other
so
thing
this
you
is
said about 30% reduction in PTH reduces the fracture
what they
risk.
wanted to look. Yes,
Yeah.
what they
So
wanted
the
to look
numbers needed
basically.
to expose they are saying is low, but it
Yeah.
is
The
not really low.
number needed for numbers
Yeah.
needed for an effect
Yeah. So
at
it's
the
quite high.
highest
It's like
decile
300
is
people
200
need
to
to.
300
Yeah.
with a this one 95
Reduce.
95% confidence interval of 172 to 1000 something.
Yes,
Pretty large.
Hmm.
correct. And that too to reduce one event.
To resist one fracture event. It's quite a large population to treat. The other thing that in that data that I found was a little disconcerting is only 51 patients had transplant and got excluded out of more than 3,20,000. So
Yeah.
is Japan doing so less transplants? Or is that some kind of a red herring there? How only 51 transplants? Because this
Exactly.
is the complete data set. 98% of Japan's dialysis population is there in this data set.
Yes. One thing is they have excluded PD, and Japan is also high on PD. So if you
Hmm.
realize that, so transplant patients may also be coming from the PD group also,
Yeah.
as well as the yeah, I mean preemptive transplants. So those, I mean, so there would be more transplant population probably coming from the preemptive as well as the PD group. But yes, definitely that also caught my eye that a very small percentage of patients on hemodialysis transplanted that year.
One of the suggestions is Japan doesn't believe in brain death, and they do non-beating heart donor brain death transplants. So it's very possible they have living donor transplants, and these patients possibly get donors very fast and don't stay on dialysis for so long. That is the only possibility that I can think of from this data, because the average duration of dialysis is almost 60 to 70 months,
Yes.
which is almost 5 years plus. So I don't think these are patients who have a transplant prospect, and
Hmm.
non-beating beating donors, and of course ABO income. We all know why ABO incompatible transplants started in Japan, because they don't believe in brain death. So they don't have beating heart brain death donors. So that is possibly one issue why this cohort didn't have such a large conversion into a transplant. But it's very counterintuitive. And we have Dr. Sanjay Agarwal who's raised his hand. If the moderator could just take a call from that. Sir has.
Uh, I think. Uh, so, so could you make the panelists? I mean, Dr. Sanjay has to be made the panelist to speak. So could you type the question so I can take it up? Sanjay
So
sir,
if you
could you
could type your question in the chat box, I guess the moderator could take that.
The
otherwise?
important learning point was that I think the low PTH does protect from hip fractures. So I think that's a very useful learning point there. So targeting a low PTH might protect our patients from inadvertent hip fractures, which we see and make the patient's life more difficult, and they are very difficult to operate and mobilize afterwards.
Because they haven't mentioned what kind of mimetic or vitamin D analog they
Yes.
use to achieve these PTH levels. That is also another thing. These are the disadvantages of observational studies, I guess, where it's such a large population. So I guess there is going to be a very wide variation in what kind of drugs that are used to achieve this intact PTH level.
I have one
But
comment.
it is very good that Dr. Mridula covered the intact PTH analysis and its significance. And of course, it was very nice for Dr. Indu to have spoken on RCS. I had one full sheet written so that in case I had to pitch in. So thank you very much to ISN for giving us this opportunity. And of course, there is another thing which Dr. Mridula missed. There is a very small byline that on the second page where it says serum calcium levels were corrected for the albumin concentration using Payne's formula. Would you like to say something more about that, Dr. Mridula?
Sir, so the correction of calcium is done as uh, with respect to the albumin, as there is my free calcium is also there, and then it is bound to the albumin. So for calculating the corrected calcium, we find out the difference between the standard albumin value, and then we take the difference and then multiply it by 0.8, and then we add it to the value of the
Measured
patient's
calcium.
lab value.
So
So
good.
that
So
is the
just like how the Cockcroft-Gault formula for creatinine clearance was derived in 1960s on a cohort of 65 patients, you must remember that Payne's formula was made in 1973 on a cohort of 200 patients, out of whom 20% had hyperproteinemia related to multiple myeloma.
yes, sir.
What
That
is assumed, and we continue to assume today, is that because calcium is predominantly bound to circulating albumin, the calcium and albumin relationship is linear. That is, as albumin goes down, the value of total measured calcium goes down. Over time, it has been learned that this is not so.
yes, sir.
This is not so.
There is association with
And,
the
and
level of IgG also, sir.
actually, a decline in serum albumin is not really associated with a decline in overall calcium. There was a study by Smith in 2018 where they said that the calcium values derived by Payne's formula only agreed in 55 to 65% of patients, while the unadjusted calcium values were in agreement in 70 to 80% patients. More importantly for us nephrologists, this relationship is further skewed in patients on hemodialysis with significant overestimation of calcium values. And the lower the albumin, the poorer the performance of the formula, which means when you try to correct it more, you are actually going to overestimate by a large amount. This formula is really not something which these authors should have used with the current available evidence as far as its relevance to dialysis requiring patients and definitely total calcium, because they have compared it with the ionized calcium too. So that is one thing which I found interesting. And of course, you have covered the PTH assays and how they are important. And the authors have themselves mentioned about the circadian rhythm. For all residents, you have to be aware that the sample for intact PTH is to be collected in a very specific way. The syringe has to be cold. It has to be collected into a cold syringe and transported to the laboratory in the cold syringe on ice. This is a very simple precaution which I find most blood collection labs do not follow. So it could give you a falsely low intact PTS level.
Thank you, Dr. Ranjit, and thank you, Dr. Amol. Thank you, Mridula, for the kind
Thank you, sir.
presentation.
Thank you.
We have reached the time limit. And Dr. Indu for the beautiful explanation about the.
I'm sorry, Dr. Darshan, your voice is breaking off in between. Your audio, I can't get your audio in between.
Let me check. Thank you. I would like to conclude the session for today. Thank you all for participating and pitching in. And there were not much Q&A today in the session. Probably everyone was stuck with the methodology. They couldn't find their head through the spline. Probably after Dr. Indu's slides, I think we have a more, I could say we have a better analysis, better belief in how the analysis could have been done. Thank you, Dr. Indu, for the slides. There's one comment talking about the cadaveric transplant and the Japanese population where religious beliefs come in the way for increasing for the low numbers of cadaveric transplant. Thank you. Thank you all for joining in. Thank you, Dr. Nair and Dr. Amol again.
Pleasure.
Yeah.
Thank you, ISN, for giving us this opportunity and for us to learn the RSC splines. Thank you so much.
Thank you.
All the best, Dr.
Yes.
Mridula.
Thank you, sir, for the opportunity. Thank
Well
you,
done,
sir.
Dr. Mridula. Good, good. Keep it up.
Thank you.